Assalamu alaikum, and a very good afternoon to all. Welcome to the plenary session of the 24th Shaukat Khanum Cancer Symposium. I'm Alina Sadaf. I'm a pediatric oncologist, and it is my great privilege this year to serve as chair of this symposium. When I was first asked to do the introduction of the plenary session as chair, I had hoped to dig through archives of our past symposia to find inspiration that I can share with you all. But I needn't have worried because the experience of this symposium, the warm embrace of halls filled with eager scientists and participants, students and teachers, is a living testament to the rich 24-year history and stature of this conference. When we take some time to reflect on the significance of this moment at the cusp of almost a quarter century, the importance of our work becomes self-evident. This symposium has served as a steady ship in the turbulent tides of our time through COVID, conflict, climate change. The symposium has been a pillar of resilience, and this is quite in line with the legacy of Shaukat Khanum. This year, we've had a record number of abstract submissions, and I must thank the Abstract Review Committee for their efforts. They are an esteemed panel of expert nurses, clinicians, scientists who sort through all the abstracts, score them on the merit of their science, and select the best to be presented at the symposium. We offer a number of awards, including that for Best Free Paper and Best Poster Presentation. Tomorrow, 6 of the best free papers from the medical division, allied and basic sciences, will compete for the coveted Esset Rashid Memorial Award. The best free paper from the nursing division will compete for the Begum Mir Research Award. And finally, the Bashir Alavi Award will be presented to the best publication in cancer research in Pakistan. So I'd like to take a moment now to thank everyone. And I recognize I have not moved my slides. There we go. So, thank you, first of all, to the hospital leadership for their continued commitment to the advancement of cancer research in Pakistan. Thank you for steering this ship. I'm grateful to my co-chair, Dr. Tabinda Sadaf, for her support. Thank you also to Dr. Muhammad Faisal. Thank you to the organizing committee and the scientific committee for coming up with a scientific program that is both balanced and diverse. Thank you to all the speakers for their valuable time. Thank you for making it all the way here. All the participants who have submitted their research and attended as audience. The Symposium Secretariat, thank you particularly to Ms. Anika Aga for the outstanding planning and logistical expertise. The IT department, they are the silent heroes of the day, making every effort towards a seamless experience for this hybrid conference. The Marketing and Business Operations Department for their untiring efforts in promoting the symposium. Thank you to the Marketing Department for catching us in our best light and for some memorable photographs. Special thanks to Mr. Farooq Aziz for the excellent preparations of our venue. Thank you to the Transport Office for arranging safe and efficient transportation for our guests. Thank you to the porters, the volunteers, the ambassadors, and the security personnel. Finally, thank you to our online audience for participating and posting questions. We hope to continue the tradition of this symposium for many years to come and we hope that you will join us on this journey, God willing. Now, it is my distinct privilege to introduce the next speaker, Dr. Asif Loya, Medical Director of Shaukat Khanum Memorial Cancer Hospital and Research Center in Lahore. Dr. Loya is a prominent pathologist and an accomplished researcher in his own right. As a leader in healthcare, Dr. Loya has played a pivotal role in shaping Shaukat Khanum Hospital into one of the premier comprehensive cancer centers of the region. Dr. Loya is currently out of the country on official hospital business, and he's joining us online. So over to you, Dr. Loya.
Thank you, Dr. Alina, for this kind introduction. I hope you can see my slides and you can hear me.
Yes, we can see your slides and we can hear you.
Thank you. Assalamu alaikum and good evening, good afternoon, good morning, wherever you are. At least it's good morning where I am at the moment. Thank you for coming in such large numbers to this year's symposium. So what I'm going to show you are some of the struggles and the issues that we face with the practice of oncology in our country. And then I'll talk a bit about our hospital. So my talk with regards to challenges that we face with regards to cancer care in this country will be based on the burden of disease, the number of cases that we see every year, the statistics related to that, the diagnosis and the issues related with the diagnosis, the problem with the availability of treatment facilities and the trained personnel, the data, the registries, the costs that are associated with the treatment of cancer in this country, the regulatory issues, and obviously the research culture that we really need to inculcate into our institutions. So the burden of disease, 180,000 new cancer patients are diagnosed every year in this country, and out of these, half of them do not survive. This is low relative to the population that we have in this country, but it's very high relative to the facilities that are currently available, or the dedicated cancer treatment facilities, I must say, that are currently available in this country. Shaukat Khanum Memorial Cancer Hospital being one of them. The diagnostic delays stem from the fact that the patients and the physicians are not aware of when to really go for whether the lump that they're feeling, as an example, is cancer or not. There is lack of awareness. There are various stigmas that are associated around these cancers. Female patients especially, and those having lumps in the breast, are shy to go to the doctors and get themselves evaluated, and hence leading to delays in diagnosis and treatments. Children, people feel that children cannot have cancer, or even if they have cancer, getting them treated will lead to many other issues. There are paucity of diagnostic facilities in the country. There is poverty of knowledge as to what is the best method of diagnosing cancer and eventually treating them. So the cancer patients that we get, a lot of them actually present at the advanced stage at presentation. We have excellent physicians and nurses and other clinical staff, but then there are very few dedicated cancer diagnostics or treatment facilities available in the country. And this results in a disjointed care, and a multidisciplinary approach is obviously lacking. And this is where the major issue arises. We have extreme shortage of trained physicians, nurses, or the ancillary healthcare professionals in the country. Those who are available are poached, and they are getting jobs overseas, especially in the Middle East or in Europe. As far as the training programs are concerned, the domestic training programs do exist, but they are limited to some very few institutions which have very good training programs and are producing doctors who are extremely well trained. We really need to look into developing innovative solutions. For example, hospitalists rounding on cancer patients when they are admitted, or ICU or OR technicians taking care of various issues related with the patients and taking the burden off from the physicians. Institutional registries really need to come up, institutional cancer registries. We do have a national cancer registry that has been announced, and the bill has been passed by National Assembly in August 2025. It is still in the early stages, and we can only hope and pray that this would actually grow into a big national cancer registry, which would represent the entire country. The Karachi Cancer Registry initially existed, but then it went away and it has recently been resurrected. We do have Punjab Cancer Registry and the Northwest Cancer Registry that are currently functioning from the platform of Shaukat Memorial Trust, and something that I will talk about as we move on into our slides. So the cost of treatment is, as we all know, is a global challenge, but that gets greatly amplified in lower and middle income countries. There are newer and more expensive drugs, immunotherapies, various equipments, including the radiation machines and robots for surgeries that are available, but that becomes very difficult to acquire in these lower middle income countries. And then at the same time, we feel pressures from these trained physicians and patients who are now extremely well informed thanks to the search engines and the AI generated search engines that we are now getting. And they're getting all the information from there, and they're coming up to us and asking us for the best possible treatment that is available, not realizing the costs and the availability issues are there. Obviously, the funders, donors, and media people also have a say, and they also keep putting the pressure on making sure that we get the best that is available, not realizing the challenges that we face. The provincial healthcare commissions do exist in this country. They have various standards, but the implementation of these standards is either patchy or selective. We do have professional regulators for physicians, nurses, and pharmacists. But at the same time, we also feel that and realize that there are some outdated laws that regulate many aspects of practice in this country. And this is especially to do with regards to approval of drugs and making sure the drugs are available. The society is highly litigious, and we do face a lot of litigations or lawsuits here and there, and we do have the challenge of dealing with these. We do need to work on developing the culture of research. Um, we do need to have these institutional review boards and scientific review committees available at various institutions, not only at the basic science level, but as well as clinical research. We do need to develop a collaborative environment where the research institutions collaborate with each other in making sure the data that is represented represents the entire country. In addition to that, we do need to have these clinical trial units come up and established in various institutions. And this would only encourage these pharma companies, which are currently reluctant to bring trials or prospective trials or drug trials to our country. And this would only encourage them to bring these trials to our country. Now, talking about our hospital. We currently have two hospitals functional, Lahore Hospital that was inaugurated in 1994, and then Peshawar Hospital that was inaugurated in 2015. And the upcoming Karachi Hospital, which is currently under construction and is planned to be operational in December 2026. The inspiration to build Shaukat Khanum Cancer Hospital came from Mr. Imran Khan, the former Prime Minister of Pakistan, and her mother, who developed cancer and then succumbed to cancer in 1985. The picture in the center is Mr. Imran Khan's mother. And during his mother's illness, Mr. Imran Khan, who is now in the picture as a little boy, he witnessed up close the plight of indigent cancer patients in this country and the lack of facilities that were available for these cancer patients, and specialized centers were not available in this country. This is when he decided that he would work on developing a cancer patients, a hospital for cancer patients, which would not differentiate between whether a patient can pay for the treatment or not. And this was in 1985 that Mrs. Shaukat Khanum succumbed to cancer. And in 1988, Mr. Imran Khan decided to build a cancer hospital in this country. 1989, he decided to launch a worldwide fundraising campaign. And in 1991, the construction of this hospital was started. This was in 1992 that Pakistan won the Cricket World Cup, and that gave a huge boost to this campaign. And eventually, in 1994, the Lahore hospital was inaugurated by the very first cancer patients who was treated at this hospital. And then in 2015, the Peshawar hospital was inaugurated again by the very first cancer patient who was treated at that hospital. Our mission statement really deals with to act as a model institution to treat cancer patients irrespective of their ability to pay. And this is the punchline. 75% of the patients who come to us are treated absolutely free of charge. We also make sure that we take part in educating healthcare professionals, doctors, nurses, paramedical staff, ancillary professionals. And we also do research into the causes and treatment of cancer and continue to expand in this field as well. Our core values stem from the fact that we aim to provide quality treatment to everyone, be it a patient on support or patient paying for his or her treatment, and with equal facilities available. The picture at the top on your screen is an inpatient room, and this is the only kind of inpatient room that we have in all our hospitals. So a person lying on one bed does not know if the person on the other bed is being treated on support or is paying for his or her treatment. We aim to provide holistic care. The children who come to our facilities are provided with books, and the teachers are available to teach them. So while they undergo treatment at our facility, they do not miss the school. And once they get out of the system, treated and cured of cancer, they go back to the level where they would be if they were not suffering from cancer. We have many feathers in our cap, the biggest one being the Joint Commission International, a US-based organization which a lot of you must be aware of, which accredits hospital for quality. We just recently achieved our reaccreditation for all our facilities for enterprise accreditation. Our oncological services are accredited by American Society of Clinical Oncology. Our lab in Lahore is currently accredited by College of American Pathologists, and we are aiming to have our other facilities also accredited by College of American Pathologists very soon. We have various ISO level certifications. Our hospital information system is also certified by CMMI, which is again the highest level of certification for any kind of hospital information system. Our pharmacy is accredited by American Systems of Healthcare Pharmacists, which is a training program which is currently available at both our sites in Lahore as well as in Peshawar. These are some of the numbers from 2024, and these numbers just speak for themselves with the kind of work that we are doing and the amount of work that we are doing. And obviously, with opening of Karachi Hospital, these numbers would certainly increase and almost double in number. Since 1994, we've spent staggering 784 million US dollars to provide treatment to these needy cancer patients. And again, I will repeat here that 75% of all these cancer patients are treated absolutely, completely free of charge. These are the top cancers that we see in our country. Colorectal and anal canal for men, breast for females, and then lymphomas for children. Research, we continue to, as per our mission statement, a commitment to perform research to the highest scientific and ethical standards. We have a dedicated research wing, which houses a clinical research office, a clinical registry office, and a basic sciences research lab. We have our own journal, Journal of Cancer and Allied Specialties, which is a PubMed index journal and does not charge for any of the publications. Almost 1,600 publications have come out from Shaukat Khanum's platform since inception. This is our third and the largest of the cancer hospital that is currently under construction at DHA City in Karachi, and it is planned to open its door to public in 2026. We are currently equipping it and making sure that all the latest facilities are available when this hospital opens its doors to public. Now, talking about Cancer Registry, Punjab Cancer Registry, a project which is sponsored by Shaukat Khanum Memorial Trust. This was set up in 2005, and this is the oldest population-based registry in the country, and it monitors the distribution of various types of cancers, and it is certainly the registry that gives data to WHO with regards to the data that is coming out of and representing the entire country. Since Punjab is the most densely populated province in this country, the data coming out of it is actually a representative of the entire country that WHO takes. We also have a Northwest Cancer Registry that is again sponsored by Shaukat Khanum Memorial Trust. This was set up in 2015, and this actually represents the provinces of Khyber Pakhtunkhwa, the federally administered tribal areas, the Azad Jammu and Kashmir, and the Gilgit-Baltistan. And this registry again is growing as we are getting more and more support in that region to give data to this registry and eventually represent data coming out from the entire province. So this is just to show you the statistics that are available on the WHO website. And again, like I said, WHO mentions Punjab Cancer Registry as the source of data for this information that is published on their website. And this is eventually going towards a national cancer registry. So a bit about our symposium this year. As you are already aware, this year's symposium is happening from 24th to 26th October. Like previous years, this is a hybrid meeting. And this year, we have accreditation from the Accreditation Council of Continuing Medical Education for American Medical Association Category 1 credit hours, which are available for those who are participating in this year's symposium. So this is a new feat for us that we've been able to achieve. And starting this year, our symposium is accredited by them. Talking a bit about the city of Lahore, this is an ancient historical city with a rich culture and something that everyone who is in this city wants to learn about. It is a center of learning for centuries. It has a tradition of hospitality, very hospitable people, and food to die for. I'm sure a lot of you who are here must have experienced the food already. If not, you still have some time. Please do not miss this idea of going and exploring various food options that you have in this city. The Shaukat Khanum Cancer Symposium, this is an annual event, and this is now the largest cancer meeting in the country, actually in the region now. 461 abstracts were received only this year, 119 talks, some of it were virtual. And like I said, we are accredited by American Medical Association Category 1 credit hours, 29 in total by the Accreditation Council of Continuing Medical Education. And all this is without any kind of commercial sponsorship or pharma support. And this is something that we've been making sure to achieve since years. Now, a bit about the organizing committee. These are our members of our organizing committee, but obviously I would like to start by thanking our chair, Dr. Alina Sadaf, and our co-chair, Dr. Tabinda Sadaf, for putting up an exciting program and a program that is rich in various aspects of cancer care, diagnosis, and treatment. I would also like to thank Dr. Mohammed Faisal, who initially started working on this program, but then eventually he had to leave and Dr. Alina Sadaf took over as the chair. And we cannot leave this page without thanking the backbone of this entire symposium, and that is Ms. Anika Aga, or Ms. Anika Salman. She has been a backbone of every symposium for years and making sure that organizing committee is working fine, and all the organizations related to the symposium are spick and span and up to the mark. At the same time, are Mr. Nasser Salim and Farooq Gul, a part of our liaison team, who sometimes spend the entire nights at the airport receiving guests. Mr. Farooq Aziz Khan and his team for making sure that all the arrangements at the hotel are up to the mark. This is our scientific committee and their members of the scientific committee. Our speakers are coming from various leading hospitals and universities of the world. We have 62 national speakers this year, 42 international speakers that are representing 14 different countries. We had pre-symposium workshops on Thursday in pathology, anesthesia, and surgical oncology. Ever-increasing number of free and original research papers are keep coming up in our symposium. But the biggest session that everyone waits for every year is Hassan Rashid Memorial Medal session. And sometimes people start preparing for this session almost a year in advance of the actual symposium. In addition to that, we have a Bashir Alawi Award for the best cancer publications from Pakistan. And every year we have this award come up, and this has been going on for almost 3 years now. We do also have a Begum Me Research Award for Best Nursing Paper to be presented during the 24th this Cancer Symposium as well. And all this is coming up tomorrow, so please do not miss these sessions, as they are really the highlight of the symposium, and they do happen the very last day and the very last session of the symposium. Now, it is my privilege and an honor to introduce and to welcome Dr. Julie Grallo, who's the Executive Vice President and Chief Medical Officer of the American Society of Clinical Oncology. She is our distinguished plenary speaker at this year's symposium. I would leave it to Dr. Alina Sadaf to formally introduce her, but I just wanted to welcome her to our symposium this year. Eventually, we do have a symposium app that you can download both on iOS as well as Android platforms. And it has all the information available about the symposium app and all the CME credit hours that you need, and the feedback that you need to fill up to get these credit hours can be done on this symposium app. With this, I would like to thank everyone for their attention, and I would hand the mic over to Dr. Alina Sadaf.
Thank you, Dr. Loya. So it is a profound honor and a true privilege for me to introduce our esteemed plenary speaker, Dr. Julie Grallo. Dr. Grallo currently serves as the Chief Medical Officer and Executive Vice President of the American Society of Clinical Oncology, known as ASCO. She is Professor Medical Oncology and Global Health at the University of Washington School of Medicine. Previously, she was the Jill Bennett Endowed Professor of Breast Cancer at the University of Washington School of Medicine, Professor in the Clinical Research Division of the Fred Hutchinson Cancer Research Center, as well as Director of Breast Medical Oncology at the Seattle Cancer Care Alliance. Dr. Grallo is a recognized leader in breast cancer clinical research and has conducted clinical trials in breast cancer prevention, treatment, and survivorship. Dr. Grallo served in leadership roles for the SWOG Cancer Research Network funded by the NCI, including as Vice Chair of the Breast Cancer Committee, Executive Officer for Breast and Lung Cancer. We are especially grateful to Dr. Grallo for joining us physically here in Pakistan, making the long journey to be with us in person. Her presence today is a testament to her genuine commitment to collaboration, shared learning, and supporting oncology communities across borders. We deeply appreciate the time, effort, and goodwill this visit represents. Please join me in extending a warm welcome to our plenary speaker, Dr. Julie Grallo, and in thanking her for honoring us.
Thank you very much for that warm introduction and for including me in this really amazing symposium. I'm really impressed with what you've put on, all of the different sessions and speakers. I was asked to speak in the plenary about global strategies for equitable cancer care, and I'll try to do that some justice, but I'm going to start by telling you a little bit about ASCO's global impact and strategies. So although we have that American in the name, ASCO is truly a global organization. We, about 40% of our members are from outside of the US. We have 51,000 members total, representing 170 plus countries. ASCO membership, as of the last 2 years, is free for all members in training, but what's new is members in low and lower middle income countries are also free, any health professional. So what about Pakistan membership? ASCO has 561 members from Pakistan. You are number 11 right now. Egypt is number 10, and they only have one more ASCO member than you. So I am hoping that by the time I step down from the stage, you will have surpassed Egypt and be in the top 10. It's free. So, and there are lots, hopefully you will see there's a lot that we have to offer you in exchange. Now, at our annual meeting, some of you have been to that. It's huge. We have 45,000 members. We've held it in Chicago for the last many years. And again, attendance at that meeting is 40% international. What about from Pakistan? Well, at our most recent meeting in June of 2025, we had 27 Pakistan members in attendance. 2 were online, but 25 were in person. And we had 161 abstracts submitted from Pakistan, 5 selected for posters, and 136 were published. You do have a real presence. Now, our global strategies for equitable cancer care fall under these domains: education and training, leadership development, access to care and essential cancer medicines, quality cancer care, and cancer research. We created a couple of years ago, after I took on the role of Chief Medical Officer at ASCO, what we call our Center for Global Impact. We used to call it our Department of International Affairs, but we really wanted to give it some oomph and some prominence. The purpose of this center is to integrate global perspectives into all of our strategies and operations and to make global impact. We have a new and improved global webpage. We know that our website is not very easy to navigate, but that will change soon. But if you just go to asco.org/global, you can find a lot of information about all of our global activities. So it's asco.org/global. We decided about 5 years ago that since we were growing globally, internationally, that we needed to get feedback from our international members about what ASCO programs and services you wanted from us and what you might want tailored a bit to your own context and culture. So we first formed an Asia Pacific Regional Council in 2019, followed by a Latin America, Sub-Saharan Africa, and Central and Eastern European Regional Council. Now, with the free membership in low and lower middle income countries, India is now number 2 in terms of ASCO membership. If we really wanted, you could surpass not just Egypt, but India in terms of ASCO membership. So we have an India advisory group where we're trying to ask them, how do we best serve you? But do we actually expand to the India's subcontinent? Which might include Pakistan. I understand all of the relationships that are complicated here. Within the Middle East, we also struggle with how we serve a role. And so, at least for right now, we have a memorandum of understanding with the Egyptian Oncology Society, who in turn have memorandums with 12 other countries in the MENA region. And we are using that to ask, what do you want from us and to offer opportunities tailored to the region. I know Pakistan fits kind of right in between there. So maybe we just need to address Pakistan itself directly as a country and not try to lump you into a region. These are some of the regional council activities. Though our Asia Pacific Regional Council said, we love your leadership development program, but you only accept 16 people a year. It's hard to compete. We want our own Asia Pacific Leadership Development Program, which is a year-long program with mentorship. You work on a team project. So we've now had 2 classes of leadership development in Asia Pacific. Latin America is going on now, and we have one planned with our Eastern and Central Europe Regional Council for 2026. Our Latin America group came to us and said, we want more intensive research training, clinical research training, and we want more opportunities to actually apply for research opportunities that aren't competing with US and other high-income countries. So our International Clinical Research Scholars Program is also a year-long program. It kicks off with an in-person meeting, but there's mentorships and regular interaction while a protocol is developed over the course of a year. So we've had Latin America, Sub-Saharan Africa, and the applications for Asia Pacific just closed. We have a variety of international courses, and we collaborate with the societies and institutions around the world. Our main topics for our ASCO-led international courses are multidisciplinary cancer management. You get to pick 2 types of cancer you want to specialize in, tumor board development, palliative care. We have an interesting one that was developed when I was on our ASCO International Affairs Committee called Cancer Prevention and Screening and Referral Pathways for Primary Care. So focused on how do we bring the primary care community, which is responsible for the awareness and the screening and all of that of our patients, and how do we connect them with the oncology community in the area. We have an international course in clinical research, and then all of them have a train the trainer. So you might pull a group together to have one of these courses, and then those who graduate from that can go out to their regions and their institutions and do a modified version of the course. Of course, you held a Best of ASCO just recently here in Lahore. That is a course that's not put on by ASCO, but it's ASCO materials provided, and it's a licensed course. And I was asked by our vice president of our Center for Global Impact to tell you that next year we will be announcing a request for proposals for virtual and in-person palliative care training that would be free. You decide how and when you want to do it. So if you're interested in that, just keep an eye out. We haven't quite announced this yet. We fund a lot of research awards and grants, and our foundation is called Conquer Cancer. And we've also taken a chunk of those awards and given them an international specific focus. So our Young Investigator Awards, we have almost 50 of them now that we give out every year. We decided to take about 5 of those and tag those just for global oncology. So they're reserved for global oncology. We have an International Innovation Grant, which is about $20,000 to $25,000. It's usually NGOs in partnership with the cancer center that have a short-term project that they want to kick off. We have a long-term international fellowship award where an applicant is applying to spend, it's up till recently been a year in the US or Canada. Because we could only offer a couple of these, we've decided to redo them. And I think the announcement will be soon that we're going to make them shorter, 3 to 4 month awards where you come and have mentorship at an institution in the US or Canada, but we'll be able to offer more of them. And we have an International Development and Education Award. I'll tell you a little bit more about that in the next slide. And then we have one Women Who Conquer Cancer International Mentorship Award given every year. So we've really tried to reserve a subset of our awards for the international community. We gave away more than 11 million in grants and awards just last year. So that IDEA Award, the International Development and Education Award, supports early career oncologists in low and middle income countries. And what it offers is you can attend the ASCO annual meeting. We pay for you to travel there. We hook you up with a mentor and their institution. There are trainings and opportunities in Chicago during the annual meeting. And then for a few days at the end, you get to go to your mentor's institution. And this really develops long-term relationships. And these IDEA recipients are used as a pool for ASCO committees and other activities in the future. Since 2002, when we created this award, we've had 461 IDEA recipients from 73 countries. 7 of our IDEA recipients to date have been from Pakistan and 3 from Shaukat, Khanum. So congratulations to those. We'd like to see more applications from you. With respect to our awards, which I've overviewed a little bit, those with a global focus, we have research grants that can be across the spectrum of the research cycle, preclinical, translational, clinical, all medical specialties, not just medical oncology. But we've never had an ASCO member in Pakistan receive a research award. So let's change that. We, in order to support you in preparing for these awards, we have grant writing resources, virtual office hours, recorded webinars, examples of successful applications, and helpful articles. So let's change that. We put out a policy statement about 2 years ago, about a year ago, I guess, on global equity in clinical trials, basically saying we need to support clinical trials everywhere. And we've heard a little bit about Shaukat Khanum's investment in that and contribution to that. We need to be doing trials that are relevant to the context, the community, the populations, and not just assume that results, for example, from drug trials that are done mostly in higher income countries are relevant with the same toxicities and outcomes in other environments. We created several years ago the Journal of Clinical Oncology, Global Oncology, JCO Global Oncology. Dr. Catherine Van Loon is our new editor-in-chief. This was to create a journal that actually publishes global oncology research that was having trouble getting into our other ASCO journals. And if you are from a low or lower middle income country, there is no publication fee if you are the first author. It is open access, so free to everyone. With respect to access to care, we did a survey a few years ago now in 2021 of our members of how can ASCO add value to you, your patients, and cancer care in your country. And overall, we looked across different resource levels, different countries. The top 3 responses were that we could help with access to essential drugs, with registries, and with pathologic diagnosis. Here's Pakistan being surveyed. You actually put prevention and screening and training for general practitioners as your #1 here, which is interesting. And that ASCO course for primary care providers and oncology might be of interest to you if you still feel the same way. But you put access to essential meds and then registries as 2 and 3. And I'm very happy to hear that you now have a great effort that's been approved for a national registry. Well, ASCO really can't do a lot about getting drugs into a specific country, but availability and access to essential cancer medicines is more than just the cost. And we did a big effort after the survey to look at what are the barriers to essential cancer medicines besides just the price. And it's defining which are the highest priority drugs, defining their value, what is on the WHO essentials medicines list. It is about cost, not just cost to the cancer center, cost to the patient. Accessibility, are they included in your budgets and your national cancer control plans? And are they accessible through procurement and transport, getting them across the border? Are they quality drugs? I mean, we have a lot of problems with the generic drugs with maybe not such high quality, and regulatory oversight of where do they come from. The delivery of drugs, you need a good healthcare workforce. You need to know how to give the drugs and deliver them safely. So you need a health systems infrastructure, and you need chemo safety standards. And then you have to figure out how to optimally utilize drugs. We need guidelines, pathways, availability of biomarkers. Increasingly in this era of precision oncology, you don't know how to treat a patient unless you've done next-gen sequencing, et cetera. And then you need to monitor and evaluate patients and deliver them safely. This is where ASCO is best poised to make a difference. We can help define high priority drugs and optimally use them. So we joined an initiative of the Union for International Cancer Control, UICC, called ATOM, Access to Oncology Medicines, because we said we can bring in our expertise with these 40 other public and private partners in helping get global access to essential cancer medicines with the focus on low and lower middle income countries. And it's not just getting the drugs, but building capacity to use the drugs. So our contribution to this coalition is in education, capacity building, and quality care. The intent of the ATOM coalition is to improve the capacity for low and lower middle income countries to receive and use cancer medicines. They're starting with 5 to 10 countries, make available at least all of the medicines on the WHO's essential medicines list, and then secure some voluntary licenses to get some newer medicines still on patent for access in the target countries. You'll see here that there are 46 target countries eventually that the ATOM Coalition hopes to interact with. There are 10 capacity building countries. You are one of them, okay? I point out that you are one of them that's in the works. And in 2025, ATOM is launching in 3 countries, Zambia, Mongolia, and El Salvador, coming soon, Uganda and Honduras. A big part of, if you're in the 10 and we've now got 5 that are coming, look, being the next one is actually political will. We need your governments to sign off on this and to be a partner. So just so you know, you are on the list, but we might need some push to get the political will because we need an MOU with the country. ASCO has committed to high quality care and helping define that. Going back to the 1990s, we started our development of guidelines to help oncologists define what quality care is. We developed our Quality Oncology Practice Initiative with our first pilot in 2002. And then we developed a quality training program, which is where we help groups come and say, we aren't doing so well in this metric. Let's get a whole team together of everyone involved in that and do a quality implementation program. What is the root cause? And let's fix it. And then our newest launch is called, it's the evolution of COPI, and COPI Certified is our ASCO Certified. COPI, our Quality Oncology Practice Initiative, is a 3-year certification that recognizes high quality care in outpatient hem-onc practices, and it validates the practice's commitment to quality and safety. It is mostly about the safe delivery of chemotherapy with a comprehensive survey. And I'm happy to say that Shaukat Khanum received COPI certification in 2023. And you got a perfect score on your audit, 100%. The lead physician, Dr. Ahmed Awais, also serves on our ASCO COPI certification steering group, and you were the 6th country outside of the US to have a COPI certification. So congratulations on that. And I see that we'll need to add Karachi here in the near future when it opens, right? This is the next step. So COPI certification is mainly about the chemo safety, the delivery, taking care of the side effects, et cetera. So ASCO certified is now based on a broader oncology medical home that adds 6 additional categories for certification, 7 domains total, that add patient engagement, availability and access to care, evidence-based medicine, equitable and team-based care, quality improvement, and then goals of care, palliative, and end-of-life discussions. So we now have offered this throughout the US. I think we have 2 ASCO certified sites that are international now, one in I guess, Ireland and one in Greece, with several more on the way. And so this would be the next step. If you really want to take the next step, would be to go beyond COPI and look at whether you might want to consider being ASCO certified. Our guidelines, we have our high income sort of evidence-based, high quality guidelines. And we have some global or resource stratified guidelines in a few key areas: cervical cancer, palliative care, colorectal cancer, ovarian, metastatic breast, and the one we just released, geriatric oncology. And this is the metastatic breast cancer guideline. And we're working on tools of different ways of presenting this. I mean, the guideline itself, if you've looked at them, it's a PDF. It's a detailed, complicated, dense, hard to read, publication. But we're creating summary tables and algorithms and podcasts and YouTube videos. We want to hear from you as to what resonates with you. The younger generation says, we want a podcast on it. It just seems like that's what we're hearing. What would work best? What are the tools here? And I'll congratulate Dr. Ziba Aziz, who's from Pakistan, who serves on our ASCO Global Guideline Advisory Group. Another way that we've partnered globally is at the city level. So Adam partners at the national level. At the city level, we partner with what started at UICC, City Cancer Challenge. This is where a city can come together and the government officials, the institutions, the care providers, the patient advocates, and say, we're committed to improving in our city into cancer control and care. And so these are the cities that are currently recognized. Some of them have been on this long enough that they're kind of graduating out as more cities. But ASCO contributes to this with leadership development, multidisciplinary care, and palliative care training. I don't know why Lahore wouldn't look at maybe, could we be a City Cancer Challenge city? My favorite part of all of this, and I've gone to some of the multidisciplinary courses and stuff we do when we kick off a city, is we developed a leadership program for women in oncology, where one woman from each of the city is selected to be part of a year-long leadership development course. And bringing these women together from very different backgrounds and countries and all has been very fun. And we're in our 2nd cohort of that. We also have virtual mentoring in communities. If you can't travel, we have this virtual mentoring program, global mentoring. We have 3 Pakistan participants in the ASCO virtual mentoring program in 2025. I asked them to look up how many people had taken advantage of that. We have room for more. We have an ASCO Oncology Student Interest Group for medical students and residents, and we have 2 sites at the medical schools at Aga Khan University and Khyber Medical College here in Pakistan. And then we have these online communities. ASCO we just provide an infrastructure, but our members can choose to join these online communities on various topics that are of interest to them. Some are more active than others. The International Medical Graduates is actually probably the most active with the most members. The Women in Oncology, the AI one is really taking off too. So I'll just give a slide or two about something that we just launched that's exciting to me after a full career in global oncology, is the development of a global cancer financing platform. And we launched this during the UN General Assembly Week last month in New York. So this started with a White House roundtable on the development of a global cancer fund to be modeled after the Global Fund for HIV, TB, and malaria, but with a focus on cancer. And that was in October of last year. So just a year ago, we had this first 100-person stakeholder meeting at the White House. After the election, we met quickly at the White House again as a small group to say, are we going to be able to keep this going with the new administration coming in? And we said, we sure better. So what we did was, by April of 2025, ASCO agreed to contract with Dr. Catherine Young, who was the lead for the Global Cancer Moonshot, on behalf of all of the stakeholders. This is not an ASCO-led project, but we contract with her to pay her salary for a few years to continue work on developing the Global Cancer Fund and bringing the stakeholders together. So at our annual meeting in June, we had a Global Cancer Fund roundtable where we tried to develop what would be the scope of this fund and how would we finance it in this era where the US and other countries are pulling out in many ways. We can't be seen as being competitive. We need to find new sources of funding and financing. And in September of 2025, we announced the launch of what we're now calling the Global Cancer Financing Platform as a side event at the UN General Assembly. So the scope that we decided on as a group of stakeholders was stage shifting, downstaging, and cervical and breast cancers as a launch point. And the potential financing mechanisms, we have people much smarter about finance than me, have been working on this, would involve, they had to have transparency, but innovative financing mechanisms, diaspora remittances, dormant assets that are just sitting there at the country level, not being used, blended finance, public and private partnerships, et cetera. So at the launch, we had the launch of a pilot. The Ugandan ambassador to the US announced that they would take the lead in the first pilot of a diaspora remittance pilot with Uganda. And it turns out there's about $100 billion a year that goes to the continent of Africa from the diaspora to families. $100 billion. If we could capture 1% of that, that would be $1 billion a year that has not previously been used for health in any way that could come into such a fund. And so we're working with Uganda, and as soon as Uganda stuck their neck out and said, let us be first, we now have a bunch of other Central and Eastern African countries that said, we'd like a regional cohort. We're looking at either taxing the remittance companies, they charge a lot, and they are talking to us, like a 1%, and or we would tax the family 1%, but give back in health coupons, for example, none of this is fine, 3 times that in health coupons for any kind of health care. Okay, so I think this is very innovative, and it's finding a source of funding where we're not competing with prior sources of funding. We also unveiled a declaration of support that formalizes a commitment from the whole world toward working toward this global cancer financing platform. And the early signatories are shown here. Uzbekistan, Gabon, Guatemala, Kenya, Nigeria, Uganda. We have several more that have signed on since we're going to do another launch. We'd be very happy to have Pakistan sign on to this as well and work together. There's a website, www.globalcancer.finance, where you can learn a little bit more about this developing fund. And with that, I would say that our key to our global strategy at ASCO is partnership and collaboration. Our vision is a world where cancer is either prevented or cured and every survivor is healthy. We cannot achieve that vision without being global and working with all of you. And I'd like to thank you for your attention.
Thank you, Dr. Gallo, for that wonderful talk. I think Dr. Asif Loya is online for his closing remarks for the plenary session.
Thank you, Dr. Alina, and thank you, Dr. Grallo, for this very interesting talk, giving us the various perspective and the various initiatives that ASCO has taken globally in bringing the entire global cancer community together and helping us bridge this gap that is there globally. I would like to thank everyone who attended this session, and I hope that you will be attending the rest of the sessions tomorrow. Some very interesting sessions coming up, especially the research related sessions, the SN Rashid Memorial Medal session and all. So please do attend, and I look forward to your um presence in those sessions. Thank you very much, and hope you've enjoyed the session.
Thank you, everyone. That concludes our session.